Hello, I hope you are having a good day today. Today, I'm hoping to show a patient case that was presented to me and how to manage this patient, or if there are any ideas that could be used to help manage this patient's psychotherapy medications. So, this patient is a 58-year-old male admitted to the hospital for decompensation of schizophrenia. Patient has previously been admitted to the facility on 3 occasions. This most recent admission is due to a stabbing of a neighbor 4 times in the chest, who he believed was either a cyborg or aardvark, and he has been hospitalized at this location for 9 years. So the chief complaint of the patient is he reports feeling side effects from his medications. He feels like he's overmedicated and the risk of the medications are outweighing the benefits. So he reports having memory loss, swollen ankles and face, liver problems, excessive fatigue, gait disturbances, and blurred vision. Patient is frustrated. He has been on such a high dose of antipsychotics for so long. And his primary diagnosis is schizophrenia paranoid type. And his secondary diagnosis is psychoactive substance dependence. And he has other comorbidities as well that is often seen with patients with schizophrenia. Family history. His father is deceased. He has a history of alcohol and drug abuse, but he's not able to do that in the facility. So let's take a look at his medications. He's on some medications for cardiometabolic issues, and it seems like every day more and more people, especially in the United States, are having cardiometabolic issues with hypertension, high cholesterol, and diabetes. So he's not unique in that sense, but let's look at his psychotropic medication. He's on Depakote 3 times a day. He's on fluphenazine 30 milligrams a day. He's taking Ativan 1 milligram TID. He's taking olanzapine 30 milligrams at bedtime. It's a pretty good dose. And then he's taking risperidone 2 milligrams every morning and 4 milligrams at bedtime. And he also has 2 milligrams he can take on an as needed basis if he has any breakthrough psychosis. He is also on trazodone 100 milligrams at bedtime and zolpidem 10 milligrams at bedtime. Alright, so let's look at the past psychotropic medication history. The patient was resistant to clozapine and had side effects that made him unable to tolerate it. And most of the treatment guidelines for schizophrenia, they recommend clozapine for treatment-resistant schizophrenia, and they recommend it last line usually due to its adverse drug reaction profile. Past clozapine, it's kind of a lot of prescribers have to figure out what they're going to do with that. Clozapine augmentation is one step, but we have to try multiple antipsychotics, especially if somebody isn't responding to clozapine. So 3 total antipsychotics are currently used with this patient, with each having a partial response. Prescribers felt that the patient got more benefit when the antipsychotics were built on top of one another, even though there wasn't a history of trying to decrease another when one is started. There's a history of Parkinsonism side effects like tremor, shuffling gait, and rigidity in the patient. Upon admission, patient was verbally aggressive with staff and other patients with significant paranoia. Patient was also refusing medication during this period. So let's look at what we see with this patient. Overall, the patient appears to be stable from an aggressive perspective, but does continue to cycle and have visual hallucinations. He sees sperm floating around the air and fixates on this delusion and thinks he can tell whether somebody is sexually active if he can see sperm floating around above their head. Patient has extensive history of aggression and violence prior to admission to the hospital, but has not had such incidents recently, with the exception of a verbal altercation with the treatment team he goes to see about level status and privileges. Patient recognizes that he has a mental illness that requires treatment. However, he expresses the desire to be removed from certain medications due to perceived adverse effects. He has a list of coping mechanisms available to him that he reports using regularly with success. These coping mechanisms he uses to help manage his anger, and he feels like the more coping mechanisms he develops, the less medication he needs to be on. So the patient, his speech is clear but blunted and slow with some rambling. He reports that he isn't as sharp as he used to be, and he still reports some paranoia, especially in settings where he doesn't recognize all the individuals. So let's look at our assessment and plan and possible ideas we can throw out. I'm not recommending anything, but just throwing out ideas here and how we can possibly alter his therapy so he can get more benefits and less side effects and make him more tolerant to his therapy. So there's also some labs we have to look at that are relevant. I especially want to focus on the free valproic acid. That's probably the most remarkable in our case. It's a level of 15.6. The free valproic acid is the active form of valproic acid. It's the valproic acid that's in the bloodstream that's not protein bound and is actively having its effects on the body. We do have free valproic acid in those who may have chronic disease states or in the elderly or have high cholesterol, those that can affect protein binding, or those who have higher doses of Depakote. But his is 15.6, and that's why they did free valproic acid. So let's look at some evidence and see if we can apply it to the plan of treatment. First off, he is on multiple antipsychotics, and I was wondering if there's anything we can do with all these antipsychotics. Clinically, there is no evidence that exists to prove that antipsychotic combinations are superior to monotherapy, and the 2009 port recommendations for schizophrenia do not support their use. Some data do, however, show that antipsychotic polypharmacy was superior to monotherapy in treatment-resistant patients. Patient is currently taking 3 antipsychotics: risperidone, fluphenazine, and olanzapine. First off, the patient is having these side effects. It would be helpful to get serum levels of these drugs to determine if any of the levels are past the recommended target range, and to see if that risk outweighs the benefit if they're out of that target range. The patient is highly treatment resistant and has been on the same regimen for at least 4 years, and he is still symptomatic. So it gets to the point like he's still having symptoms. Should we keep him on all three antipsychotics, or can we discontinue one and him still have the same level of symptoms and just not be on as many antipsychotics and gain those side effects? When determining which antipsychotic to decrease dose or discontinuing, we need to factor in the antipsychotic's adverse effect profile, the antipsychotic's effects on positive, negative, and cognitive symptoms of schizophrenia, and patient-specific needs. So let's look at each of the drugs that the patient is on individually and look at some key points about these drugs. For fluphenazine is the first drug the patient was on when admitted, and patient was reported to be responding well to the drug. I'm not sure how well because they added on 2 antipsychotics since then. But the patient's overall improvement while on this medication, it may be appropriate to keep fluphenazine at the same dose, theoretically. Potent dopamine blocker with little effect on serotonin receptors is kind of fluphenazine's mechanism of action for treating schizophrenia. Fluphenazine is a strong dopamine blocker, and dopamine blockade in the nigrostriatal pathway causes extrapyramidal symptoms. So fluphenazine is most likely out of these drugs to contribute to extrapyramidal symptom side effects, even though there are some studies that say second generation antipsychotics like olanzapine and risperidone have extrapyramidal symptoms just as frequently as first generation antipsychotics like fluphenazine. But mechanistically, we would think that they don't. So for olanzapine, it can have anticholinergic and antihistaminic side effects. It also has pharmacological blockade of serotonin 6 receptors and has been shown to produce a promnesic effects in a number of memory tasks, which basically means that a patient can remember things better and it improves their cognition. It's also a strong antagonist on serotonin receptors 2A and 2C, and it could help with negative symptoms and cognitive symptoms. Olanzapine has shown superiority over some other antipsychotics, including haloperidol, and its effects in treating chronic hostility and aggression in those suffering with schizophrenia. Olanzapine is also unique because there was a large Cochrane meta-analysis that showed that olanzapine may be more effective than other atypical antipsychotics except for clozapine in treating the symptoms of schizophrenia. Olanzapine and clozapine are sort of unique antipsychotics because they block the dopamine 4 receptor more so than they do the dopamine 2 receptor. We aren't really sure yet what that means, especially since pure dopamine 4 antagonists haven't shown to have antipsychotic effect. It's just some neat little tidbit that may show benefit in treating schizophrenia. We just aren't exactly sure what it is yet. Olanzapine, we also have to be careful for cardiometabolic side effects, especially in someone with already diagnosed metabolic disorder like this patient. The third antipsychotic the patient is on is risperidone. Risperidone has an active metabolite, paliperidone, and they have a similar receptor profile and similar affinities for those receptors. They work a little bit differently on a molecular level, such so that They say that paliperidone sort of works like a mood stabilizer, such as lithium or valproate. There was a study done in rats that showed they had a similar reaction on phosphorylation and mitochondrial effects. But basically, when you give risperidone, it's like giving two antipsychotics. Risperidone has a strong affinity for serotonin 7 receptors and has some alpha 2 adrenergic receptor blockade, which can contribute to procognitive and antidepressive effects in those with schizophrenia. Strong antagonistic on serotonin receptors 2A and 2C could help with negative symptoms and cognitive symptoms such as memory impairment or cognitive impairments or executive functioning impairments. The expert consensus guidelines suggested that clozapine and risperidone would be a good first-line choice for chronic aggression and schizophrenia, which is another reason why we may not decide to change risperidone in this patient, because aggression can be an issue. Risperidone can cause weight gain and hyperprolactinemia. So the plan for this patient is factoring in the variabilities of the side effects, patient-specific symptoms, and evidence-based medicine. I think it may be worth a trial of tapering the dose of fluphenazine down slowly, and if there's no decompensation of symptoms from the patient, potentially withdraw therapy completely. It was the first antipsychotic that the patient was on, and I always think it's worth giving a chance if we add a second antipsychotic to see if monotherapy would be better than dual therapy. And fluphenazine had the least amount of evidence that showed it helps with aggression. This patient is having these extrapyramidal symptoms, so a second generation antipsychotic would be better. In general, I think second generation antipsychotics are better than first generation antipsychotics. I read a review talking about how first generation antipsychotics are neurotoxic, while the second generation antipsychotics can be neuroprotective. So what I'd like to see first is probably a decrease in fluphenazine. The patient is worried about risperidone building up in his fatty tissue and causing side effects. But all lipid-soluble drugs absorb in the fatty tissue, and it kind of helps with their release and increases their half-life, so it's not necessarily a bad thing. So the next problem that we should look at is the patient is wondering whether he needs to continue the valproate because that was given to him for his hostility, and he feels like his coping mechanisms are helping him manage his hostility and aggression, and he hasn't had any aggressive outbursts in a while now, so he's wondering why he needs to take it, because he's having perceived side effects of blunted effects, impairment in memory, causing liver issues, causing facial edema and swelling in ankles, and also sedation. The patient was started on Depakote shortly after admission for the management of his hostility and aggression. The 2009 port recommendations do not endorse the use of mood stabilizer augmentation in treatment-resistant patients of schizophrenia, stating valproate has not demonstrated sufficient efficacy to support a recommendation in people with residual positive symptoms in schizophrenia. Evidence supports the use of valproate add-on for management of aggression and hostility associated with acute exacerbations of schizophrenia, which makes us wonder, is it really good for maintenance? So let's look at the studies. In patients with moderate to severe disease severity showed that the treatment effect in schizophrenic patients did not have any significant difference between those treated with antipsychotics augmented with valproate and those treated with antipsychotics with placebo or without the valproate. The duration of treated also yielded different results. So trials that looked at less than 4 weeks showed a quicker reduction in positive symptoms and faster discharge in the valproate augmentation group. Aggressive symptoms are linked to positive symptoms, and one of the first recommendations to control aggressive symptoms is to decrease the positive symptoms. So this helped resolve paranoia and the paranoid schizophrenic subtype within the 4 weeks as well. But trials longer than 4 weeks showed no significant difference in the improvement of symptoms of schizophrenia. So let's look at a patient-specific factor. He has serum free valproic acid level of 15.6. The target range is 6 to 22. We decided to do a free valproic acid level because this guy's a little bit older. He has all these comorbidities. He's on all these medications. So we thought free valproic acid level will be more reflective of his true level. So considering all this information, even though I said that there's not a lot of evidence for adjunct valproate in the treatment of paranoid schizophrenia, I'll give you some anecdotal evidence. My friend is on Invega or paliperidone, and he's also on Depakote, and he says when he stops Depakote, his hallucinations return. So sometimes evidence-based medicine doesn't really reflect what happens in all patients. It really is an art form in psychiatry, and really listening to the patient is extremely important. We're kind of unsure why valproate may have this effect. It could be due to a number of reasons. But when it comes to this patient who doesn't want to take Depakote, he feels like he's having all these side effects, a trial of a reduced dose of valproate can be done given that the patient is not exhibiting any aggressive symptoms, and that's why he was started on it. And he says he is managing his anger through coping mechanisms. So why don't we do a small decrease in Depakote, decrease the bedtime dose from 500 milligrams to 250 milligrams, giving a total daily dose of 750 milligrams of valproex. And we need to make sure we monitor for any decompensation. So the third assessment for this patient and concern that he had is the medication side effects he was having. He was having shuffling feet and pseudo-Parkinsonism, tremor, cogwheel rigidity. And this is associated with the long-term use of antipsychotics, as well as higher dosage of antipsychotics, and also the number of antipsychotics. Any one of them can cause pseudo-Parkinsonism in their own right, and I can imagine what 3 would do. So effects seen in the patient, since he has a long history of being on antipsychotics, may be permanent, and major adjustments of medication may result in the deterioration of patient's mental status and prognosis. Patient is currently on benztropine or cogentin, which is a strong anticholinergic to treat the extrapyramidal symptoms. Another strategy besides anticholinergics for extrapyramidal symptoms is to use a dopamine agonist to counteract the pseudo-Parkinsonism. Amantadine is an old drug that is sometimes used. It's generally as efficacious for pseudo-Parkinsonism as anticholinergics, with significantly less effect on memory dysfunction. One thing we need to be careful of is amantadine has the adverse drug effect of worsening psychosis. So this seems to be really bothering the patient. He wants to get back to doing activities such as work, and his shuffling gait makes it hard for him to balance. So let's think about maybe adding a dose of 100 milligrams of amantadine every day, and perhaps increase to 2 times a day if patient sees benefit, and monitor carefully for adverse effects. I think we still need to continue the benztropine since it's an antimuscarinic, and these sort of combat pseudo-Parkinsonism by 2 different mechanisms. So the second adverse effect patient was reporting was excessive fatigue and sedation. The patient is taking trazodone and zolpidem to help with sleep, which are both highly sedating. He's taking a high dose of zolpidem or Ambien, 10 milligrams at bedtime. I think he's taking 100 milligrams of trazodone at bedtime. The patient reported that he is on trazodone for restless leg syndrome. Perhaps he was started on it for akathisia and pacing, and trazodone can be used to treat akathisia. But for sleep, trazodone and zolpidem is a duplication in therapy, and they're a contraindication because they're both used for the same thing. Patient is also on olanzapine, which has a strong affinity for histamine receptors, which also cause sedation. So all these sedating meds, we have to wonder why he's having these excessive fatigue and sedation side effects. So I think we should possibly decrease the Ambien and trazodone and monitor patient for insomnia or akathisia, and hopefully his fatigue and sedation, daytime sedation, will resolve. So his next complaint is blurred vision. This could be due to increasing age. It could be due to his hallucinations. He's talking about seeing sperm everywhere. Or it could be likely associated with his anticholinergic use, benztropine. Psychotropic drugs can also cause blurred vision. Trazodone can cause blurred vision. So psychotropics in general have idiosyncratic side effects of blurred vision. He's on first generation antipsychotic and fluphenazine, and they recommend getting annual eye exams when on these medications. As far as what we can do for it right now, there isn't something that we can necessarily acutely do for his blurred vision, but maybe we can take him off some of these meds or reduce the dose, and maybe that will help him improve. He also reports a swollen ankle and face. Valproate can cause edema in up to 5% of patients. That's kind of redundant. Sorry. And lower extremity edema may also be associated with amlodipine 10 milligrams a day. So it's kind of hard to pinpoint what is causing this swollen ankle and face. It could be due to Depakote or due to amlodipine. It'd be helpful to know how long this problem has been occurring because he's been on both these medications for a while. So what we could potentially do is remove amlodipine, or we can increase both the hydrochlorothiazide and lisinopril. They aren't at their max doses. And it may be a good thing to get rid of amlodipine because it's contraindicated with simvastatin at 40 milligrams, and the patient is on 40 milligrams of simvastatin. But we can always decrease the statin dose as well, or switch the statin. And it's contraindicated because it increases the risk of rhabdomyolysis, or muscle wasting. So, and we're potentially going to decrease the valproate dose, so maybe he'll see some benefit with that too. Even small changes in therapy can make a big difference. The patient also complained that he had liver problems, but the patient's liver function tests, or enzymes, have been within normal limits for the past 2 years. While Depakote or valproate may cause hepatic problems and increase liver function tests and cause liver impairment, it appears that Albert Cutter has not had any significant problems besides his perceived problems. And the last problem on his list is cardiometabolic syndrome. The patient is on a typical regimen for diabetes, hyperlipidemia, and hypertension. His levels are stable. There is that contraindication between simvastatin and amlodipine. What we could do, decreasing the simvastatin dose may not be good, because there is research nowadays that simvastatin has pleiotropic benefits in helping patients with schizophrenia. It can reduce their total PANSS score and improved positive and negative symptoms. We aren't sure why, but we could change the simvastatin to a different statin or change amlodipine. So that about does it for his problem list. All changes, especially psychotropic medications, should be done gradually and one at a time, so it can be identified what medication is responsible for what effect. Thank you for listening, and if you have any suggestions or any ideas for this case, please let me know. Thank you, and I hope you have a nice day. And here are the resource lists, just so you can have it for reference in case you're interested in any of the studies. Oh, I forgot to cite this one, sorry. So I'll go through this one more time. I apologize about that. I forgot to cite the statin one.